Welcome, everyone. Thank you for joining us for today's webinar, Laboratory Medicine Beyond the Box, Value-Based Healthcare and Diagnostic Evidence. It is presented by Dr. Elizabeth Marlowe, who is the Global Director of Medical Affairs for Microbiology at Roche Molecular Systems, and Joanna Sickler, MPH, MBA, who is the Director of Medical Affairs for Point of Care at Roche Molecular Systems. My name is Judy O'Rourke, and I will be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want during the presentation. Simply click on the Ask a Question box located on the far left of your screen and type your questions into the drop-down box. Our speakers will respond to your questions via email following the presentation. If you have trouble seeing or hearing the presentation, please click on the Ask a Question box to let us know that you're experiencing a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located in the top right corner of the presentation window and follow the process to obtain your credits. And now, without further ado, please join me in welcoming Dr. Elizabeth Marlowe and Joanna Sickler. I will now turn the presentation over to them.
Thank you, Judy. And I would like to thank the organizers of this speaker series for inviting us to join today. So the title of our talk is Laboratory Medicine Beyond the Box. I'm going to be speaking on the first half, talking about value-based care as it relates to laboratory medicine and thinking about where the laboratory fits into this paradigm. And Joanna is going to be speaking more about how do we think about generating the diagnostic evidence that's required for value-based healthcare. So at the end of this presentation, you should be able to recognize the changing model of laboratory medicine, define value-based care, discuss the challenges to leveraging laboratory data, and understand the skill set that's going to be required for the next generation laboratorian. Now, as we think about technology and we think about how things are changing, I can't help but think about Blockbuster. Now, one might be thinking, what does Blockbuster stores have anything to do with laboratory medicine? But what's pictured here is the last Blockbuster store in the world. And this is in Bend, Oregon. And what's ironic about it is probably about 15 years ago, there were maybe 9,000 stores around the world where anybody could walk in and rent a video on any given Friday night after a long week at work. And I recall doing this probably about maybe 20 years ago, 15 years ago with my husband, and the owner of that store coming up to my husband saying that he was closing the store because the way that home entertainment was going to be delivered was changing. Now, fast forward 15 years later, and we see the last store that survived these changes in technology, and that the way consumers expect that this technology is delivered to them. And I actually have to appreciate the fact that the last Blockbuster actually has a sense of humor too, and they actually have a Twitter account. So, as this one says, a lot of people don't know this, but we own a large portion of Netflix. Just kidding, our electricity just got shut off. Now, I say this in tongue in cheek, but really, as we think about healthcare and we think about where healthcare is going, there's a lot of similarities between what happened to Blockbuster and where we're going with healthcare. So as we think about that, let's think about how do we want to define value-based care. So value-based care is defined as a healthcare delivery model in which providers, including hospitals, systems, and physicians, are paid, not paid based on fee-for-service, but based on patient health outcomes. And under value-based care agreements, providers are rewarded for helping patients improve their health, reduce the effects and incidence of chronic disease, and live healthier lives in an evidence-based way, which is key to our talk today. The value in value-based healthcare is derived from measuring health outcomes against the cost of delivering those outcomes. And this is what's going to be very key as we move forward and seeing healthcare change. So what you're seeing in this slide is really, it's life expectancy versus healthcare expenditures from about 1970 to about 2015. And what you can see on this slide is that the U.S. outspends most developed countries and actually some underdeveloped countries as well. And what we spend is not reflected in the outcomes. Life expectancy is shorter than most other developed countries and many developing ones. And actually, I looked it up since in 2017, there was additional data, and those costs have gone up to over $10,000 annually per person. There's a lot of reasons for this. One of them is the lack of healthcare insurance for a lot of people, also the fee-for-service model in the U.S. We could go into a lot of reasons, but at the end of the day, it can't sustain itself, and we need to start thinking about doing things differently. And if we think about healthcare expenditures and where we're spending our money, what you see here is what are the healthcare expenditures for laboratory? Laboratory healthcare expenditures account for about 2 to 3 cents of every healthcare dollar that we spend. And you have to ask yourself, how many more pennies can we be squeezing out of that 2 to 3 cents? Not a whole lot more. There's somewhere between 4 and 13 billion laboratory tests performed annually in the U.S. It's the single largest volume medical activity, and it's estimated to impact 3/4 of all medical decisions. So when we think about where we're spending our money, perhaps we need to start thinking about that 98 cents as opposed to squeezing more out of that 2 to 3 cents. And if we start to think about the shifting model of healthcare, you have to think about where the laboratory is in its life cycle. For many people, they're so focused on lab consolidation, cost containment, that they're not looking up to see that really the lab is shifting from a cost-driven service to a provider of medical value. And this is where we are seeing things shifted as we move from a volume to value-based system. And with that value-based system will be more innovation. Now, with the laboratory and innovation, our job has a lot to do with introducing new technology. But the reality is if you build it, it's not necessarily true that they will come. Introducing new technology into a healthcare system is complex, and I always said in my laboratory that the science was the easy part. It was really everything else that went around it that made it more difficult. And we'll get into this a little bit more as we get into Joanna's talk. But what often slows the adoption of new technology is the cost of bringing it on and physician comfort level in practice. And while you can sit down and estimate an ROI on any technology you want to introduce, the true ROI requires a voice from the laboratory because of many of the complexities. And we'll get into these in a minute. So what does it take to have a winning diagnostic solution? And what does it take to really truly push diagnostic technologies forward, especially in the evolving reimbursement paradigm that we're in? Well, number one, we have to recognize that FDA approval is only the first step towards wider adoption and the evidence that is required for payers as well as administration. We need to maximize the data integration opportunities that can be utilized in the EMRs or electronic medical records. And that integration of data really needs to support appropriate diagnostic test ordering. It needs to have minimal disruption to the clinical care workflow. And we really need automated safety nets that can identify gaps in care and support test interpretation, and that can further be converted to reimbursement opportunities to generate revenues and reduce costs for the system. And lastly, we need to develop evidence-based literature that truly demonstrates medical necessity and outcomes. So let's just take a moment to take the laboratory perspective. Operational challenges are tough, and every time I show this slide in an audience and I say, who can feel the squeeze, every hand in the audience usually goes up. The laboratory is faced with changing technology, constant budget cuts, further reimbursement cuts thanks to PAMA, a shrinking workforce. The average age of a CLS in the U.S. is somewhere in the mid-50s, and we have about a 60% shortage of laboratory scientists going into the field annually. There's a worldwide shortage of pathologists. People don't talk about that a lot. In fact, in the UK, there was a recent publication talking about how there were delays in cancer treatments because of the shortage of histopathologists. There's legislation that is mandating certain testing, and at the same time, the lab has to respond to all this and continue to improve patient care. So as we think about this, let's just take a simple look at one example of an order. And we're going to talk about blood cultures. The Holy Grail, everybody wants to improve sepsis diagnosis. Let's just look at what it takes to work up a blood culture, one of the most important specimens that comes into the microbiology laboratory. And normally you would order 3 sets of blood cultures over about a 24-hour period. So 2 blood culture bottles come in. That's 1 order as a set. That blood culture bottle gets put into the instrument, the blood culture instrument, to get read. Usually within about 12 to 24 hours, that blood culture would go positive if it's true positive, and you'd get a gram stain. That gram stain would then be called to the floor in a timely manner. And there's new technology that once you have a gram stain and that blood culture bottle goes positive, you can run things like the BioFire or the GenMark. Accelerate now has technology. And it's an add-on test to traditional culture workup that would further require identification and susceptibility testing. What you see here is an example of some of the reporting that is seen by a physician as these test results come out. And what we have to appreciate is that for the physician on the end who's waiting for the results to manage their patient, the blood culture, the gram stain would be called immediately in a very timely manner. But from there, the physician has to follow up on that result, and they have to go in when they're managing the patient one by one into the test results in the electronic medical record. And so you can see here you have that initial gram stain result. It says that the BCID was performed, it was an E. coli, and that susceptibility is pending. And this is pretty complex, and this is just for one test order. So if we think about this and we think about introducing new technology and introducing, in some cases, technologies that's an add-on, there's a lot more to this, and we'll explore this as we go through our talk in the next hour. Clearly, there's limitations beyond just lab operations, costing out a test, and the analytical analysis. You know, oftentimes there's a lack of published clinical impact studies, and when we introduce it, we often assume that these results are reliable, providers will trust those results and know what to do with those results, but really, oftentimes they'll monitor those results, and their comfort level comes with experience. So just because you have a result doesn't always mean it's actionable and it will equate to improved outcomes. So as we talk about outcomes, there's a few things that we can do to define it. There's laboratory outcomes. That would include appropriate test utilization, reducing laboratory costs, improving productivity, better turnaround time, quality. There's clinical results such as reduced antibiotic use, decreased length of stay, morbidity, mortality, readmissions, and the overall cost to the healthcare system. So as we're measuring outcomes, we need to make sure that we're all using the same ruler across studies, and what's really going to be getting the attention of administrators or the C-suite is that overall cost to the healthcare system. So what you see here on this slide is an example of some work that was done in my former institution, and this was a study that was presented in 2011. In my lab, we had been an early adopter of PNA FISH technology, which is a probe-based technology for probing positive blood cultures. And we were being asked by our administration about 6 years after adopting it, given the cost of adding this technology, what kind of outcomes we were seeing, what kind of bang were we getting for our buck. So what you're seeing here is the results of about 262 chart reviews that were done based on some PNA FISH results. And this was done by RID physicians, and you can see that it was scored. It was scored a 0 if treatment could have been altered by the technology, but it wasn't, so they were on inappropriate therapy. It was scored a 1 if treatment was not altered, so they were on appropriate therapy. It was scored a 2 if the patient was discharged or transferred. It was scored a 3 if treatment decisions should have been altered, but wasn't, so there was an education gap. And it was scored a 4 if treatment was guided with the help of that technology. And what you can see from this result is less than 14% of the time did we actually impact the utility of that PNA FISH. And so what it demonstrates is that, the test wasn't necessarily being intended at its maximum utility. If we fast forward to the end of 2018, this paper was published looking at the BioFire blood culture ID system, where they actually looked at 6 months prior and 6 months after implementation of the technology, and they looked at outcomes, not only lab outcomes and time to first identification, but they also looked at antibiotic escalation, de-escalation, length of stay, discharge. And what they found is while they significantly reduced the time to ID, they did not reduce any time to appropriate antibiotic escalation, de-escalation, or length of stay. So we still have a ways to go, and I'm going to let Joanna get more into this as we talk about introducing technology in evidence-based medicine. But with that, I think we need to talk about data. Because for me, the lab is just a rich sort of data, and how do we manage that information flow, and where are the value opportunities? So as we shift from this value or volume to volume-based world, this is what it feels like for most of us when we're dealing with data. It's just coming at us, and we're drinking from the fire hydrant. And how do we expect for providers managing patients to be managing the data that's coming from them, especially as we're seeing diagnostics get better, more precise, but more complex? And this is where I think the lab has a huge opportunity as a member of the care team. What I like to think of the laboratory really is not as a service, but really as the data command center. This is a picture of the CDC Data Control Center, and really they service as an early warning system and response network when it comes to outbreaks. The laboratory basically has the same task within a healthcare system, and I think we have an opportunity here to function in a data-driven world and provide more value as we leverage that data. The problem with data and dealing with data is there are gaps that we have to manage. Number one, data's dirty. If you've ever tried to do an outcome study, you know how difficult it can be to access that data. And once you do get access to that data is make sure that data is valid. And while there's a lot of really smart people data scientists out there, we really do need the right experts who can ensure the accuracy and application of the data that we're trying to utilize. There's been a call for analytical frameworks so that we can actually have a system to getting to this data, but we need analytical frameworks that allow for transferable solutions across systems. It needs to be generalizable, and we need analytical outcomes for actionable usability. We need information that can be provided that provides actionable information, and this can come in a variety of forms, be it providing clinical decision support for earlier diagnosis, personalized intervention through laboratory interpretation, population risk stratifications, improved disease monitoring, and we need an ability to document the impact of these diagnostic interventions on outcomes. When we think about diagnostics and the role of data analytics and information, this is what it looks like today in terms of an antibiotic stewardship. It typically doesn't happen until after a test result has been ordered and reported. But really what we need is we need to recognize that diagnostic stewardship is part of antibiotic stewardship, and it should be happening before antibiotic stewardship so that the lab has an opportunity to fill gaps in care, guide clinical decisions through consultation, and improve reimbursement, and ultimately improve care. I think what's encouraging is there are digital solutions that we're really in the early phases, but we're seeing digital solutions in AI already in laboratory medicine. There are pilots that have been published on that are occurring in certain systems looking at providing risk scores for things like a septic patient or an infection control assignment. Perhaps this patient is at higher risk for developing C. diff. There are analytical steps in terms of workups and where digital solutions are playing a role. In pathology, it's whole slide imaging. In microbiology, as you can see pictured here, there's microbiology plate screening and reading algorithms for sorting and working up these cultures. We need to do a better job in a more thoughtful way of thinking about improving our reporting and how we can integrate some of these digital solutions together. But I think it's on its way, and we're going to see a greater impact on that patient care. And as we're moving through this and we think about what kind of skill set we need for the next generation laboratory leader to manage all of this, we also need to be thinking about alternative delivery strategies to healthcare. Because the reality is that the way that healthcare is being delivered is changing. It's moving away from the old brick and mortar model of care where you go see a physician office or go to a medical center. Really, we're seeing integrated systems that can be provided in a lot of different settings. There's Doctor on Demand, which essentially lets you to FaceTime a doctor for your phone. My husband's a huge fan of it. There's remote diagnostics. In my former institution, we used to send out fit tests for colorectal screening to our members, and we had a very high success rate. And we saw a lot of change coverage in those patients, and where we were seeing there was data showing that they caught disease earlier and people survived longer if they did catch disease. There are companies that have remote diagnostics associated with STI screening. That's all done via the internet. And if we think about the way this is transforming, really, I think we should be looking to how retail is transforming, because there's a lot we can learn. But the question becomes is, where will the laboratory fit in this evolving landscape? I think we do analytical really well in the laboratory. The places where we really need to be thinking about things is pre-analytical and post-analytical. What will specimen collection look like? Do we need to have special kind of devices? Are there population screening versus diagnosis strategies that we need to be thinking about? Will testing be done in a centralized model or a decentralized model, and who will be providing that oversight? And how will the lab laboratory be able to continue to provide that oversight? Post-analytically, how will we be reporting results? How will we be ensuring that there's no patients lost to follow-up? What will reimbursement look like? And what quality metrics will we be incorporating given these new models? Well, it's a lot to think about. I think it's just important to understand that the laboratory director of the future needs to be considering this value and thinking about how they can impact healthcare in any setting, because laboratory testing will continue to grow. So with that, I know there was another talk in this series regarding Clinical Lab 2.0, but if you're interested in learning more, I would encourage you to go to their website. It really is a grassroots effort looking at the future of value-based care and the placement of diagnostic services in the American healthcare system. And they're a very motivated group, and they've got a lot of great ideas, and you may want to learn more about them if you haven't already. And if you're interested in hearing more about my thoughts about the next generation laboratory leader and the skill set that we're going to need, I have a recent editorial that I wrote talking about a laboratorian in post-technology world. And I have the website there for the Clinical Microbiology newsletter if you're interested. And with that, in summary, laboratory medicine is shifting. It's shifting away from a consolidated, cost-contained environment towards really being a provider of medical value. And while technology is certainly a part of the solution, it's not the only solution, and introducing technology alone is not going to improve outcomes. With that, we need the next generation laboratory leader who's really positioning the laboratory no longer to be viewed as a commodity or a service, but rather as a strategic asset, where they have a tactical role of data center, where we can really optimize care and reduce costs. We do need an analytical framework that will allow for standardized metrics, and this will allow us to capture and assess both impact and support resources. And with that, the next generation leaders in the laboratory will need the right skill set that will allow them to be that champion that allows us to leverage that laboratory data for improved medical value. And with that, I thank you for your attention, and I'm going to hand it off to my co-presenter, Joanna Sickler.
Thank you, Beth. And I'd also like to thank LabRoots for the invitation to speak in this series. Beth gave us a great strategic picture of how to leverage the value of the laboratory. What I'm going to focus on is more getting into the nuts and bolts of the evidence and what the actual evidence is that's needed in order to show that value. By the end of this presentation, you should be able to define the different types of diagnostic evidence and common endpoints in order to show the value of the lab, and understand what the drivers are of the shifting evidence landscape. What you'll see as I go through this presentation is that the bar continues to be raised on the level of evidence that's really required to show value. And I want to walk through some of the reasons why this has happened. First, I think it's important that we recognize that tools are not always used as intended. And this is a lesson in the healthcare space that has been seen time and time again by payers and time again by healthcare institutions. And this has been a key driver of why the evidence bar is shifting. Just because something may make something happen, time and time again, they've seen that new diagnostics aren't necessarily having the impact that's been projected. So first, let's really get into that evidence and the different levels of evidence that are required to show value. From the industry perspective, we really used to think about the world 15 years ago as ending at FDA approval. Our role was to develop an assay and go through the regulatory process. After that, it would slot into the lab and our work was done. However, more and more we've come to realize that the evidence required for regulatory approval isn't enough. The bar keeps being raised and we need to be developing more and more types of evidence. So let's start with the basics. So the first level of diagnostic evidence is clinical validity. This is sort of the classic evidence package that the FDA requires for regulatory approval in the US. Can the test correctly identify the biomarker or the disease that is intended to detect? Typically, endpoints include sensitivity and specificity, positive predictive value, and negative predictive value. This is the first level, and I would say sort of the bread and butter of evidence development for diagnostics. When we think about how the world used to be and how, again, from an industry perspective, we used to perceive it, is our goal was to improve these metrics. We want to develop a test that is more sensitive and specific than the test that was there before. Here's an example thinking about point of care influenza tests. Over time, new technologies have been introduced that have improved the sensitivity of point of care detection. Today, molecular point of care tests are available that bring that sensitivity to being on par with routine laboratory centralized diagnostics. So what we've seen is the sensitivity go up. But what this also has resulted in is that the cost of a point of care test has gone up. And the question we're asked time and time again is, what is that value of that improved sensitivity? Is it worth the extra cost? Is what we had before good enough? And that question of good enough and really showing why a more sensitive test or a quote unquote better test is adding value to the healthcare system is the challenge that we're continually faced with. And that brings us to our next level of diagnostic evidence, clinical utility and impact. So how does introducing a better, a more sensitive, or perhaps a more specific test actually improve the management of patients? That could look at issues like the distribution of antimicrobial therapy. It could impact what types of additional tests have to be ordered. And we more and more need to really think about that, right? What is this test going to be doing to change how physicians are going to manage their patients? So a really important step in thinking about evidence development is generally to have a hypothesis, to have a belief in how we think a diagnostic will actually change management. And I want to be clear that this is the really important next step, right, is to think about what we think could happen. And developing this evidence is a key piece of the pyramid, and this is something that I do again and again in my clinical study program. However, this is a step. It isn't the final destination. And more what we see is that words like if, had, and could aren't going to get us to the evidence level we need to be at. Why is that? Well, it comes back to what Beth mentioned and what I mentioned earlier as well. This assumes that clinicians are going to follow the results of the test and behave exactly as we theoretically intend. And I think we know that in any system, humans do not always do that. As a result, that brings us to our next level, which is impact on clinical practice in the real world. So in the real world, when a test is implemented, how is it actually used? And is it used in the way it was intended? And therefore, are the results that could happen actually happening? As I mentioned before, tools are not always used as intended. So Beth mentioned the example of a BioFire test for a bloodstream infection. And this is also from that same study where in one clinical setting, what they found was that they weren't seeing the practical match the theoretical. Well, in theory, implementation of this test should have changed clinician prescribing behavior. In their actual institution, they didn't see it. And something we need to take a step back and think about when we implement new diagnostic tests are, what are the stakes and what will truly be required to change behavior? When you think about doing something like implementing a more sensitive strep A test for pharyngitis in a primary care setting, I would argue the stakes are relatively low. Asking a physician to look at a test result and make a determination about whether or not to prescribe an antibiotic. If they end up making an ultimately incorrect decision, the consequence is most likely that that patient will come back and they will change treatment. Looking at something like bloodstream infections, we are on the complete opposite end of the spectrum. The stakes in some ways couldn't be higher. A clinician is worried about making the wrong decision. A clinician is worried that if they prescribe the wrong therapy or change therapy at the wrong time point, that this could have incredibly serious consequences for the morbidity and mortality of their patients. As a result, we need to recognize that just implementing the technology is oftentimes not going to be enough. We also have to be thinking about the overall systems and processes that are going to be in place to support clinicians and an institution to best use these new technologies. And that brings us to sort of our final step in the pyramid, which is where we wish we could always get to, which is clinical outcomes, right? How does implementation of a new technology influence things like mortality, morbidity, hospital length of stay? The reality is it's oftentimes incredibly challenging to develop evidence to demonstrate these types of outcomes. Beth mentioned that in the real world, data is very dirty, and it's oftentimes very difficult to look back. Other times, for certain types of conditions, it can be challenging to find a large enough patient population to actually show a statistically significant result. Practically, in the world we live in today, getting to showing real-world impact on clinical practice is oftentimes going to be a bar that's high enough. But that doesn't mean we shouldn't continually strive to show the clinical outcomes and a positive impact on patients from an outcomes perspective when we implement new technologies. There's one of the classic examples when we talk about outcomes is genomic health and the implementation of the Oncotype DX test. This is a company that's known for sort of having done everything right in terms of really developing an evidence package to show that the utilization of their test was changing patient care. However, one of the things that's interesting about what I would say has typically been thought of sort of as, the classic way to do things right story is more recently we've had some new evidence come out that is indicating that in some populations and in the real world, they aren't still seeing those results. And I bring up this point just to make the ultimate point that this is really hard. It's one thing to look at a theoretical evidence pyramid. It's important to understand these different levels of evidence, but it's also important to recognize that it's challenging. It's challenging to discern the difference between what's going to happen in the real world and in a research setting, and it's challenging to generalize results across different populations. To summarize, all of these pieces of evidence are important, and I want to be clear that this isn't to say that clinical validity doesn't need to happen. All of these things need to happen, but we need to recognize that we need to be continually striving to improve how we develop diagnostic evidence and how we demonstrate that the diagnostics we're implementing are truly having an impact on patient care. Now I'm going to switch gears to talk about another aspect of the nuts and bolts of how we actually do this, which is to understand our stakeholders. There are a lot of different stakeholders when we think about the healthcare system. Within the health system, you have the clinic labs, the clinicians, the hospital C-suite, and the patients. Oftentimes when looking at the world from the health system perspective, you don't necessarily see all the external stakeholders who are also in play and important to consider. You have industry who's actually developing these diagnostic tests. You have employers that's providing health insurance. You have government policies. And you have payers who are increasingly, based on their decisions about what they're going to cover, influencing what is happening in our healthcare system. What's critical is to recognize that all of these stakeholders are in play, and for any given situation, you really have to map and think about how the specific situation affects those stakeholders. When we think about adoption of new diagnostic solutions, it's also important to recognize the role that the money plays. And as much as we don't like to think it's all about the money, oftentimes decisions do follow a lot of financial factors. A key point I want to make here is that while all of this evidence I've reviewed is very important, different evidence really speaks to different stakeholders and different types of value. So when we think about payers, payers are really concerned about the cost of care reimbursed to providers. So how much are they actually paying to providers to provide healthcare? And how does that impact the total amount paid to the healthcare system? The math is going to be different for a healthcare system. A healthcare system is really thinking about how much are they being reimbursed by payers minus the cost, because that's going to equal their revenue. And so how does this impact the cost of providing care to the patient? I bring this up because oftentimes I see a lack of understanding about the fact that this math is different, and you really need to consider when you're thinking about evidence who you're speaking to and what the different pieces of relevance are going to be for them. Payers and the healthcare system, we have to recognize, is a constant sort of interface that's going to vary depending on the given situation. So you have to customize your strategy and your thinking depending on what you're thinking about in that given situation. It's not going to be a one-size-fits-all solution. If we're thinking about implementing a test that's going to fit under a DRG payment, that's potentially going to be very different than thinking about a test that's primarily going to be used in an outpatient setting for CPT codes. And it's really critical to map that entire landscape when considering the best approach. As we come to the end of this, I also wanted to make the point that, Beth put together this really great vision for thinking about how the laboratory can be a strategic asset. But many healthcare systems still need to evolve in order to be able to fully realize this true potential. This is a comic strip about the implementation of PCR at the point of care for respiratory viruses. And the discussion that these two lovely figures are having is in thinking about the flow of the dollars and how they really demonstrate value. The first little man here says, let's see, capital expense, consumable service contract. What's this? I'm figuring about how much it would cost to do point of care PCR for respiratory viruses. Sigh, it's a big increase in the lab budget. So the other one asks, why do it? Early results could lead to improvements in patient care and overall healthcare savings. That's a great thing. However, the administration says the lab cost has to be offset by budget cuts. Healthcare savings are hard to measure and may not be in the silo of the lab budget. Tell it to the kid with the cough. So it's a really great illustration of the fact that we still sometimes struggle with the way that healthcare systems are set up. And they're set up in a very siloed way. And within those silos, oftentimes an increase in the lab budget from implementing a better test, even though it's resulting in savings somewhere else in the healthcare system, it can be very difficult to have that conversation. And I think that that's really, to Beth's point, as we evolve into this new future, I think we're going to see more and more health systems evolve to be able to have this conversation. At the same time, it's really important to recognize that not all health systems are there today. So in order to really drive these types of changes, you really need to understand your stakeholders, and you also really need to understand their pressure points. For example, within the healthcare system, you can sometimes think about a payer as if a payer can get engaged with the project you want to do, and if a payer believes it can have value, that can help to put pressure on an overall healthcare system to want to drive that change as well. So in summary, the evidence required to achieve regulatory approval is step one. It's not our final destination, and we still have a long way to go. How a test could change clinical care if theoretically utilized in a certain way is no longer compelling to support value. We have to be demonstrating clinical evidence value in the real world, and we oftentimes need to be demonstrating it again and again to show the constant value. Lastly, implementation is really hard. Implementation is sort of the dirty work, right? That it's not as fun to go through the nitty-gritty of figuring out how to actually make something work in a real-world setting. But if you're going to do it successfully, you really have to understand the different stakeholders, their interests, what motivates them, and you also really need to understand the specific situation. You cannot have a one-size-fits-all solution. What worked one time in an implementation might not work in another part of your institution because it's a different set of stakeholders who are going to think about things in a different way. And with that, I'd like to thank LabRoots for the opportunity to give this presentation. Thank you.
Thank you to Dr. Elizabeth Marlowe and Joanna Sickler for your informative presentations. I would also like to thank LabRoots for making today's educational webcast possible. As a final reminder, our speakers will follow up with any questions you've submitted via email. That's all for now. Thank you for joining us. We'll see you next time. Goodbye.